Well, can everybody hear me? Yes. Okay, and I apologize. Apparently I'm kind of tethered to the podium, so if I look like an immovable object, it's because I am this afternoon, but it doesn't mean that I don't want to try to connect with you, so I'll do my best. It truly is an honor and a pleasure for me to be here this afternoon, and I thank Dr. Dukas especially for inviting me. I will be talking about emotions in medicine, and especially the emotions we give our learners, in particular medical students, about these emotions. Now, I understand that most of you here today are medical students. I see a few people who I hope are no longer medical students and have somehow figured out how to move to the next phase of their life, but I'm making no assumptions. In any case, for those of you who are medical students, I'm particularly delighted to be talking with you because I've spent virtually my whole career teaching medical students, so that although today I'm very far from home, I still feel very much at home with you all here. Now, I'm going to start off by reading you a poem, and I know that not everybody loves poetry, but because I'm a humanities type person, I do. So to kind of soften the blow, I'm going to tell you a poetry joke, okay? So, a bank robber bursts into a bank wielding a gun. Everybody screams, pandemonium ensues. The bank robber says, "Sit down on the floor and shut up, and no one will get hurt. I just want to read you some of my poems." Okay, so it's not that funny a joke, but it does speak to the fact that you have to hold people at gunpoint sometimes to get them to listen to a poem. So I hope no one here today will in any way feel held hostage if I refer on occasion to a piece of poetry. This is a poem entitled Maria by a very well-known physician poet, Rafael Campo. This G2P1 gives us a confusing history. Sounds like she's been pregnant approximately 30 weeks, although she can't recall her last LMP. No pain but bleeding for about 2 days. Of course, she hasn't had prenatal care, and God only knows where the father is. She works 2 jobs that keep her on her feet all day. She's been in the United States 6 months, doesn't speak a word of English. Bet you she's illegal. Cervical exam is unremarkable, the os is closed. I think we need an ultrasound to tell us more. Besides a look at the placenta, we need some confirmation of her dates. Her uterus can tell us more than she can. So, would someone like really quickly just to say something about this resident, your feelings, your impressions of this resident? Anybody give it a stab? Just how do you feel toward the resident? Do you like him? Do you dislike him? Are you angry at him? Feel compassion for him? Not a rhetorical question. Somebody brave, yeah?
He's treating her more like a case, not as much like a person. So
You kind of what?
Don't really like him.
I don't really like him, yes. Just for those who couldn't hear, the resident is treating the patient more like a case, and it can make us feel dislike, among other things. All right. So, we might say that the resident depicted here suffers from a kind of professional alexithymia. And anybody here, student, taken your psych rotation yet? No? Okay. Well, if you don't have dictionary.com on your iPhone, alexithymia is a psychological disorder characterized by difficulty in experiencing, expressing, and describing emotional responses. Individuals with alexithymia often demonstrate an externalized way of thinking that relies primarily on facts and figures. They're often unaware of their feelings and the feelings of others, and they are frequently described by others as cold and aloof. Now, unfortunately, although of course medical education does not literally produce alexithymia, it can unintentionally result in practitioners who are uncomfortable with and out of touch with emotion, who regard acknowledgement or expression of emotion as somehow unprofessional. But of course, we all know from our own experience that medicine is full of emotion. And how can it be otherwise if you think that patients and practitioners daily confront stressful, confusing, anxiety-producing, frightening circumstances? All of these are bound to elicit very strong emotions. And medical students, too, have feelings, right, medical students? Yeah, you do. You have a lot of feelings as part of your training. And at the bottom of this slide, I published last year a literature review on emotions in medicine, especially in practitioners. And so some of the research that I'm referring to can be found there if you're interested. But the research literature does tell us that emotional distress is common among both medical students and residents. Early on, first and second years, students often feel helplessness, uncertainty, anxiety, confusion. When they reach the clinical years, they report some positive emotions, particularly toward patients, but also negative emotions. And I want to highlight moral confusion and distress because it has a particularly robust literature. Students sometimes even report disliking patients, God forbid, even feeling aggressive toward patients. And of course, emotions can be triggered not only by patients, but by supervisors, attendings, and so forth. Okay, now, oops, sorry. Students ask a lot of questions, in my experience, about emotions, their own emotions in particular. And I think they have a big fear that they will end up detached from their emotions, that they won't feel anything toward their patients. So I think this is a real concern. But in my experience of over 30 years listening to medical students, I think they have a bigger fear. And that is that they will become overwhelmed by emotions. That if they become emotionally connected to patients, they will sort of be swept away, and that this will result in impaired judgment and perhaps even more threatening, a kind of personal vulnerability. That they're afraid to feel things. And any of us who happen to have felt something on occasion toward another suffering human being, we know that emotions can overwhelm us, can crush us, and can devastate us. So in a way, I think their fears are reasonable. Okay. Unfortunately, physicians who train our medical students are not always good role models for managing emotions. Okay, again, the literature shows us that physicians tend to distance from their own emotions. They tend to simply ignore personal negative emotions in patient care. There was a wonderful study done by Sung, Collins, and Smith in 2009. It has a more formal name than the crying study, but I like to call it the crying study. They basically were interested in looking at third-year students' views of crying. And perhaps not surprisingly, what they found is that most third-year students think crying is very unprofessional. But there was another finding in the study, kind of a sidebar, which I thought was even more interesting. Mostly students said that they had never seen an attending cry or even tear up, even get little moist eyes. But those who did reported that almost never did they see a crying attending address their own tears. That if an attending started to cry, they either left the room, came back more composed, and never mentioned their tears, or they simply continued to discuss the differential or the treatment plan or whatever it was they were talking about with tears streaming down their cheeks. And I think that this lack of ability to be present with where we are is very confusing for students, and it's very easy to draw the wrong conclusions. It's also true, as best we can judge from the research literature, that physicians are often not very good judges of reading or acknowledging their patients' emotions. For example, one study shows that when patients independently reported feelings of fear, distress, or sadness, their physicians often did not recognize these feelings in their patients. When physicians do acknowledge patient emotions, they tend to offer only minimal empathy, sort of like, that must be hard. Instead, they favor cognitive behavioral responses. So a patient may be sad or afraid, and the physician's default mode is to respond by explanation, education, recommendations, and instructions, or what are referred to as blocking behaviors that discourage further emotional disclosure, such as breaking eye contact or changing the subject. Okay. So these are all lessons about emotions from the hidden curriculum. And to kind of show you how this sometimes plays out, I'm going to show you a little clip about a medical student, a third-year medical student, and her supervising resident. Can you hear that? Can you guys hear? Hello? Okay, sorry about the sound there, but basically the medical student feels sad. The resident tells her it's not going to help her get into a good residency. He's pretty clueless about the emotional life of his patient, and when she persists, the resident recommends that she get the patient a psych consult instead of going to talk to the patient himself. And when she persists further, he says the medical student herself needs a psych consult. So medicine is obviously full of emotions, but emotions are complicated, unruly, unpredictable, confusing, and distressing. Those are the negative ones. There are positive emotions. But I don't think in medical education we do a very good job of preparing our learners to deal with these inevitable emotions. They're going to be there, but like the doctors in the crying study, it seems easier, safer, just to ignore them. And as a result, medical students often conclude that experiencing emotion is the problem and that emotional detachment or suppression is the solution. Perhaps the epitome of this attitude is Gregory House, the star of the eponymous TV show House. And will anyone here admit to watching that? Oh, look at honest medical students. Okay. Now, I don't know what it's like here in Louisville, but in California, there's a phenomenon known as house parties. You guys ever participate in a house party? No? Oh, well, see, I'm something you can import from the coast. So apparently, as I gather, a house party consists of medical students all getting together with some chips and perhaps alcoholic beverage, I'm not sure on that point, and trying to guess the bizarre diagnoses that comprise the backbone of the TV show before Dr. House and his team can get there. And for those of you who watch this show, you know that when Dr. House relies on rationality, logic, analysis, he is almost always successful. He carries the day. He saves his patient from these weird medical illnesses that they develop. But when he ventures into the emotional realm, inevitably, catastrophe results. And I think the whole premise of the show embodies a very prevalent belief in medicine itself, that the objective, detached stance of the physician-scientist is reliable and safe. It's where you should stand as a physician, whereas emotional involvement is chaotic and even dangerous. But I think there are alternative ways of thinking about emotions in medicine. For example, we could assert that being aware of and able to modulate, manage emotions in self and others is really essential to good patient care and good medical teamwork. We could argue that in any clinical context, the physician should be able to recognize when experiencing or expressing a particular emotion does not advance patient-centered goals or is distressing for the patient or the doctor. And that this awareness should trigger a process of working with or modulating the emotion to ensure that patient care and physician well-being do not suffer. And finally, that this process should occur within a context of remaining emotionally connected to rather than detached from the patient. Okay, so, and I hope you see that this kind of model, which is very similar to what's called relationship-centered care, acknowledges the person of the physician as well as the person of the patient. That if we're going to start talking about emotions in medicine, it's not only the patient emotions that matter, it's your emotions as well, and what role they play in your interaction with a patient. Okay. So the assumptions underlying this model is that when patients' emotions are acknowledged and addressed, they feel safer, they feel understood, seen, and heard, and that they're more ready to move on to instrumental aspects of care, such as agreeing on a treatment plan. It also assumes that when physicians are able to recognize and work with their own and others' emotions, they will feel more confident, more relaxed, less avoidant, which now is perhaps the dominant strategy, less avoidant of emotional situations, less overwhelmed by emotions, and less susceptible to burnout and compassion fatigue. Okay. Any comments thus far? Anything you want to? Okay. So, in previous talks, I have sometimes been accused of being the emotions police, right? So I want to make very clear that the goal here is not to make students feel certain ways or certain emotions. And it's not, certainly, it's not to teach them correct emotions, which would be patronizing and even insulting. Okay, so the goal is really to facilitate learner identification, understanding, and exploration of emotions in themselves and in patients, and to encourage learners to think about how their emotions influence clinical care, and to figure out how to modulate those emotions in constructive, beneficial ways. Does that make sense as a concept to you? Because a lot of times I think people think of emotions as something that just happens. You know, I feel happy, I feel sad, I feel mad, I feel glad. But does the idea of working with an emotion make sense? Can anyone give an example of how you have done that in a clinical context? Yeah. Okay, well, let me go on, and perhaps I can give an example in a minute. Okay, because I think the crucial question, right, is always how we move from theory to praxis, how we take lofty-sounding ideas and move them into concrete application. I don't really think we know how to do this in medical education. Have any of the medical students here, have you ever heard an attending or a faculty member address emotions or help you with emotions? You can raise your hands. You can raise your hands now. Yeah. Okay, it is very rare, but that doesn't mean it isn't important. It's just an area that's not recognized by the curriculum. And so we don't really know how to go about this. But I think as a start, it's safe to say that we need some formal curriculum addressing this issue, as well as bedside teaching. And I don't have the time to extensively go into these different theoretical models, but I did just want to mention them as things that might pique your curiosity, that you might look into for yourselves later. So, for example, there's an interesting emerging literature on emotional intelligence, which consists of perceiving emotions. For example, noticing that you're breathing faster, or your heart is racing, understanding emotions, being able to recognize that you're feeling anxious, or maybe you're really feeling angry, managing emotions, which is what I've been talking about, learning how to work with your emotions rather than let the emotions simply carry you away, perhaps toward non-beneficent ends. And finally, even using emotions to advance patient-centered goals. There is some interesting work emerging that is looking at emotional intelligence in medical students. So far, you'll be relieved to know that your emotional intelligence does not differ significantly from that of the general population. And people are wondering whether emotional intelligence might be part of the medical school application process. Is this an important dimension? Right now, to be honest, we don't know enough about it. There are a lot of measurement issues in terms of EI, but it's something to be aware of. There is a large literature out there. A related area is emotional regulation. And this goes back to the question that I asked you a moment ago, which is, do emotions just happen to us, or can we intervene with our emotions? Emotional regulation is all about addressing that particular question. And what they have highlighted is the concept of cognitive reappraisal. So that, for example, if I actually saw this several years ago in clinic when I was following a family doc and the medical student who was following her. And outside an exam room door, where they were just about to go in, and the physician paused, turned to the student, and said, you know, I really don't like this patient very much. He's not my favorite person. But over the years, I've come to really respect the fact that he never does anything that I encourage him to do without a fierce argument. And although this is annoying, in a way, I admire him for being so tenacious. This is a perfect example of cognitive reframing and cognitive reappraisal, that the physician in this case recognized she really didn't love this patient, but she also was able to share with her student a way of working with that emotion that enabled her to connect on some level with the patient. She still didn't really like him, but she was able to be a good doctor to the patient. Then just to mention a couple of other models, the ethicist Jodi Halpern has written extensively about clinical empathy. And I think one of the most interesting aspects of her work is that she defines empathy not only as cognitive understanding, which if you look at the research literature on empathy in clinical practice, is increasingly being defined as a purely cognitive aptitude. But Halpern argues that you have to have some emotional resonance toward the patient. It's not all about the head, it's partly about the heart. And I mentioned the model of relationship-centered care, which has been pioneered by people like Tom Inouye and Mary Beach. And again, this puts the emotional well-being of patient and physician as a crucial dimension of the doctor-patient relationship. But we all know that the sine qua non of medical education is not sitting in lectures like this, right? It's really what happens at the bedside in the clinic. It's really about the role models. And I do know that there's probably negative time to do bedside teaching anyway, so the idea of expanding that role may be pie in the sky. But I include here a couple of simple questions, perhaps not easily answered, but at least worth contemplating, that can be slipped in to bedside teaching or clinical interactions. For example, asking learners about feelings. When a patient receives a diagnosis of diabetes, what might she be feeling? What might the student be feeling toward the patient? And how does this sea of emotions influence what happens next in patient care? And then I think, as I mentioned, the idea of attendings and residents as appropriate, not with every patient, but when necessary, disclosing their own feelings and how they work with them, so that learners can begin to understand that this is a legitimate area of inquiry. Now, because I am a humanities type, I do just want to say one thing about how I believe studying the humanities can help us learn more about emotions. And by humanities, I mean literature, not the PubMed literature, the other literature, poetry, stories, personal essays, performing arts. In this sense, I think the humanities can enlarge our understanding of the human condition, including its emotional dimensions. When we read a novel, a short story, a piece of my mind essay, our emotions as well as our intellect are engaged, right? When we think about Maria in that poem, we have feelings about her of compassion, of caring, of distress. As we found out, we have emotions toward the resident as well. The humanities can also foster our awareness of our own psychological processes, because once we see our emotions put forth like that, we can begin to think about them critically. Again, how will this emotion help me advance good patient care? How will this emotion help me to be a good team member? You know, if you were on the medical team of that resident and you disliked him, as this gentleman expressed, how would that affect your ability to work with him? And what might you do to change or to soften that emotion? Where would that emotion lead you? It might lead you to confronting the resident, it might lead you to avoiding the resident. And I don't think there are right choices, but trying to follow the thread of how emotions influence you make you a lot more conscious. Otherwise, it's an unconscious process. Obviously, studying literature can encourage the development of empathy. You know, probably all of us felt empathy for Maria lying there, being treated as an object. And yet, is it possible to develop compassion for the resident as well? And finally, literature and the arts can help us develop awareness of the emotional meaning of illness. What is it like to be that pregnant woman here in this country, 6 months, not being able to speak the language? What is it like to be a resident who's overburdened, overworked, and is afraid that he might be missing something because he can't fully understand the language of his patient? So we're going to go back to one more poem to see if we can understand experientially how the humanities can help us explore emotion. And by way of context, I'd like to refer to a recent article in New England Journal of Medicine called Into the Water, the Clinical Clerkships. Has any medical student read that? Okay, because it's definitely been making the rounds on the West Coast, and it's worth reading. It's very short. This article was written by a longtime Harvard teacher and clinician, Catherine Treadway, and a third-year medical student, Neil Chatterjee. And in the article, the student tells the story of what happens when his first patient dies, which is nothing. No one says anything. No one on the team says anything, and they just go about their business. They move on to the next patient. The student concludes that mourning the loss of a patient, however briefly, must somehow be unprofessional. And it's a mere accident that several days later, he happens to disclose some of his emotional confusion and distress to a resident on the team, who then acknowledges that she was feeling the identical emotions. And that makes him feel better, because he feels like, I'm not abnormal, I'm not going to be a bad doctor. But except for this random initiative on the student's part, he might have drawn a very different conclusion. Okay, and again, going back to the research literature, medical students frequently mention their team's apparent indifference to patient death, and often report feeling abandoned and without guidance as to how to resolve the emotions that they're experiencing. What we learned from the Into the Water article is it's not that the team doesn't have emotions, but there is no permission to talk about them or to learn from them. This painting, by the way, is The Sick Child, painted by Edvard Munch, who is probably best known for The Scream. Okay, but it actually portrays his sister, who died of tuberculosis. Okay, so here's the poem, I Stepped Past Your Room Today, by a Canadian family physician, Jerry Greenstone. I stepped past your room today, rushed to a crammed office, rather than endure the eerie calm of palliative care. It's been 3 days now since I visited you, and that's not good. I was there from the beginning when we split your belly to find cancer erupting everywhere, the liver's glistening surface ridged and spotted as the moon. Then came the radiation, malignant clusters beamed with cobalt, bombarded with pions in a cellular explosion. And chemotherapy, specialized molecules to invade you like tissue and work their complex chemistry. But in the end, our white-coated arsenal was powerless against the long trajectory of disease. Now you lie there, shriveled husk of a man, so pale and trembling, with barely enough weight to press against the sheets. In the harsh glare of those white sheets, I see the impotence of myself as a physician, whose energy is aimed at cure and renewal. Can you understand what it means to face you like this, your courage against my fear? Let me not lose sight of what you once were and still are, a man and a father, who did the things fathers do, watched your daughter at ballet, her leaps and pirouettes, cheered your son at his soccer games, shivering in the rain, to respect your humanity, to preserve your dignity. Because if I can hold you clear enough, there's nothing more to fear. So I'm going to ask you a few questions which are not rhetorical. We'll just take a few minutes here so I can watch my time boundaries. Dr. Dukas is nodding at me approvingly, and I like approval. Thank you. So what do you think the patient might be feeling? And of course, it's very hard to know, right? Because the patient is only indirectly present in this poem, although at the same time at the center of it. But anybody take a guess? You know, no right or wrong answers. You're just using imagination, which is something you have to use with patients sometimes because they don't always tell you everything, right? Sometimes you have to wonder and speculate. So what do you think the patient might be feeling?
Grief, loss.
Grief, loss. Okay, anything else? Hopelessness, yes. And there's a hand back there, yeah. Abandoned, yes, yes. Poor patient, anger, yeah. Going to die. That makes many people angry. Yeah, and I want to point out here that what we're trying to do is enter the patient's emotional life. And just as in medicine, in clinical medicine, a good doctor is constantly generating hypotheses about her patient, right? But she has the wisdom to know that that's all it is, a hypothesis. It's not the truth until confirmed by evidence. And in a way, understanding emotions is based on the same premise, that we can think about what the patient might be feeling, because maybe if I were dying, I would be really angry. But maybe this patient is really accepting. So all I can do is think about it, and then how do we find out what's going on with patients? That's right. We ask them. We let the patient tell us their stories, right? And then we look really smart when, when you guys go out to the attending. Okay. So, what's the physician feeling? We have more information on that score.
Guilt.
Guilt. Okay. Shame. And why? What underlies those feelings? Why is he ashamed? Why is he guilty? Okay, right. His patient is going to die, and maybe he's feeling that he failed his patient. Okay, so these are very complicated emotions, and they do present a challenge, because the precipitating event for writing this poem is what? What does the physician notice? Title of the poem. Somebody speak up. What?
The door, the room.
Okay. Right. And what is he said, the title, I Step Past Your Room. Yeah. Yeah, avoidance. Avoidance because of his shame and his guilt, his sense of failure, his helplessness, which, by the way, seem to me perfectly understandable emotions in response to losing a patient that you've cared for and that you care about. There might be other emotions as well, and I think the writing of the poem is trying to generate those emotions. So the emotional strengths or promise that this physician models, I think, is his awareness of himself and is his continued awareness of his patient. Even though he would like to just run to his office and jump into the pile of papers and I'm sure his email that await him, he restrains himself from doing so and pauses for a moment to think about his own discomfort and the patient's vastly greater suffering and loss. By doing so, we don't know what happens, as in so many instances in medicine. We don't know the end of the story. But we hope by this self-examination, this awareness of his reflexive behavior, that he might end up this time entering the room on the fourth day, that he might find the courage within himself to remain present for his dying patient, and perhaps as well for the family, who he obviously knows something about as well. So I'm going to conclude with one more quotation. This is from a book called Intoxicated by My Illness by Anatole Broyard, who in the 1970s and 80s was the New York Times book literary book review editor. And unfortunately, Mr. Broyard developed an aggressive prostate cancer to which he eventually succumbed. But during his illness, he wrote this book, and this quote is from perhaps its most famous essay, The Patient Examines the Doctor. Physicians have been taught in medical school that they must keep the patient at a distance because there isn't time to accommodate his personality. or because if the doctor becomes involved in the patient's predicament, the emotional burden will be too great. As I've suggested, the emotional burden of avoiding the patient may be much harder on the doctor than he imagines. A doctor's job would be so much more interesting and satisfying if he would occasionally let himself plunge into the patient, if he could lose his own fear of falling. I'd like to think that one of our responsibilities as medical educators is to help students like you lose your fear of falling into your own emotions and the emotions of your patients, and instead to help you develop, as Dr. Greenstone did, the courage and the skill to plunge into the inevitable joys and sorrows of clinical practice. I think this makes for happier and better cared for patients, and also happier physicians as well. Thank you very much. And I think we have time for questions. So, questions? No questions? No questions? Thoughts? Does anyone here feel skeptical, or does it feel manipulative or too mechanical to even think about working with one's emotions, or does it seem so obvious that you feel it happens naturally? Yes, sir?
It was reminding me a little bit about Sir William Osler. He says this is important to know the disease that the patient has as it is to know the patient that the disease has. By knowing your patients, you're a better doctor because you know what their proclivities are, what they're going to do, and how they're going to accept the treatment. He also says something about when humanities are reduced to medicine, medical education, science.
Okay, thank you. Yeah, the gentleman here quoted the very well-known phrase from William Osler, which is that it is as important to know who has the disease, the patient who has the disease, as it is to know what disease the patient has. And I would only agree that the emotional tendencies and responses of the patient are part of knowing that patient. And it is a kind of truism, and yet it's so important in clinical medicine that different patients react very differently to the same or similar diagnoses. Anything else you'd like to bring up? Yes?
Could you comment on the extent to which dealing with some of these emotional things internally versus externally might affect the process? Because if there's not time allowed to do so explicitly, then you have to internalize it versus having a dialogue.
Yeah. So the question is addressing emotions externally versus internally, especially as a function of time. Do I understand your question correctly? Okay, yeah, thank you for asking. And I think time is both a reality and an excuse. None of us has enough time to take care of every task in medicine. And if you look at how your time is prioritized, often it kind of tends in a certain direction. So time is important, and yet sometimes we choose to run another test that maybe isn't that essential, rather than think about the emotional life of the patient. That being said, I think that some of this work is certainly internal. If as a student or a clinician, you simply once or twice a day during a patient encounter ask yourself, how am I feeling right now? Am I feeling exhausted? Am I feeling jubilant? What can I do with this emotion? How can it help me get through the day or take care of my patient? So I think that a lot of this is an internal process. Being aware of the patient's emotion offers you a choice point. If you notice a patient Here's a very classic one. If you notice a patient is annoyed because they've been waiting an hour to see you, well, depending on the situation, you might choose to address that emotion, or you might choose to simply go forward. So not every emotion needs to be addressed externally, either in yourself or in others. But I think the key thing is awareness and then making strategic choices. Anything else? Yeah, David?
Do you believe it would prove beneficial for medical students and residents to journal their thoughts and reactions, whether by prose or by poetry?
Okay, and the question is it useful to journal emotional responses? And I think that is what is known in baseball as a softball, because I'm a big proponent of reflective writing. And sometimes when we think about something, our minds just kind of whir round and round, whereas if we write it down, we get greater clarity. So I think that writing is a good thing, and keep writing, keep feeling, and thank you very much.